Good afternoon, or good morning, or good evening, wherever you may be. It's a great pleasure for me to invite you to and welcome you to the seminar in the Department of Epidemiology series of Wednesday seminars. My name is Bert Hoffman. I'm the chair of epidemiology at the Harvard Chan School, and it is my distinct pleasure to introduce Dr. Nathalie Slopen. Dr. Slopen is a social epidemiologist who focuses, as you will hear, on child development, health equity, and life course theory. She's an associate professor in the Department of Social and Behavioral Sciences here at Harvard Chan. And you will hear from her seminar that her research, amongst others, focuses on social and environmental factors that influence the health and well-being in the development of childhood and children across the lifespan. Wonderful to have you, Nathalie, and please take the floor.
Great, thank you. Well, it's really an honor to receive this invitation to present to the Department of Epidemiology. I'm going to take a moment just to share my slides, and then we'll get started. Okay, does that appear correctly for you?
Yes.
Okay, great. Okay, well, thank you again for this opportunity. So the presentation today that I'm going to give is titled Building Foundations, Addressing Housing Insecurity to Improve Children's Health. And over the course of this presentation, I'm going to give a brief introduction to cover some of the epidemiology of housing insecurity in children's health. And then I'm going to present on 3 different studies. It's a blend of works in progress and a published study as well. And I wanted to show use of a variety of different study designs that we can use to tackle this field of research, knowing that I'm talking to an epidemiology audience. And then I'll end with a few conclusions. So first, just to say a few words about myself. As mentioned, I'm a social epidemiologist with a focus on child development. And within my own research program, I'm really interested in the full range of exposures that affect child development, be it their neighborhood context, their social relationships, economic stability of the family. And over the past 5 years or so, I've had a particular interest in working on research projects that connect to housing and children's health as well. Because if we think about family and child well-being, housing is such a critical factor in order for all other aspects of a child's life and health to go as planned and as can, help children to reach their optimal form of development. And so that's how I've landed on this topic. And so I want us to begin by just saying a few words about the intersection of children with the current housing affordability crisis that we are facing in the United States. So just to begin with some statistics, according to data from 2022, data from the National Survey of Children's Health estimates that 17.1% of children are residing in households that have experienced one or more form of unstable housing, which may include experiences such as being unable to pay the rent or mortgage on time, moving frequently in the past 12 months, or being homeless at some point during their life. Other data suggests that 1 in 7 children can expect to be evicted by the time they reach adolescence. And for children living below 50% of the federal poverty line, that number is 1 in 4. Looking at other data that I'm showing on the right of this slide, we can see here that children, households that have children living in the household face increased risk of eviction. And this is true at every level of household income. Thinking about an extreme form of housing insecurity, recent national estimates suggest that 1 in 18 children under the age of 6 experience homelessness each year. And if we look at current trends in homelessness among families with children, in 2023, which is the most recent data available for this statistic, we see that there was an increase in family homelessness for the first time in over a decade. So trends are not moving in the right direction. So on this slide, I'm going to show you some data from a report that I worked on with an MPH student here, Ashna Lal. And we're providing some simple descriptive statistics using new recent cross-sectional data from the National Survey of Children's Health. And what we describe here is that when children are living in families where the caregiver reports worry about eviction or foreclosure in the past 12 months, these children are showing a twofold increase in outcomes such as anxiety, depression, behavioral and conduct disorders, and a threefold increase in having unmet medical care needs or missing in excess of school days, so more than 11 school days a year. Similarly, among children with a lifetime history of homelessness, we see very pronounced rates of these outcomes among these children as well, relative to children who have not had a lifetime history of homelessness. So 3- and 4-fold time risks relative to those without these histories, so very pronounced. And so, setting the context for the studies that I'll go into today, the main point I'd like to make here is that we have a lot of evidence, much of it coming from cross-sectional descriptive studies that show us that across the perinatal period and throughout adolescence, we see risk for worse outcomes. So during the perinatal period, we see increased risk of adverse birth outcomes. Infants are experiencing elevated rates for respiratory infections and developmental delays. Among adolescents, we see increased risk of mental health issues, as well as decreased educational attainment. And I really want to call out this particular statistic because if children don't have a stable place to live, it's very hard to get a high school degree. And not having a high school degree is one of the most important risk factors for future homelessness that exists. But I'd like to make the point that while we have a lot of descriptive research, there are some limitations, particularly when it comes to wanting to think about causal inference and intervention. So some common limitations in the prior research is that much of it is cross-sectional. A lot of the data may not be representative. We also have minimal research on interventions, and sometimes there's not a comparison group, which can make it challenging to say anything about causation. So with that, I'm going to transition us to the 3 research studies that I will talk about today. So the first study that I'm going to talk about is an observational longitudinal study. And this study uses a fixed effects design, and it looks at eviction, inability to pay rent, and youth mental health. So this is a project that I worked on with Nigel Harriman, who's a biostatistics Master's of Science student, Bruce Renfro, who's a Harvard Medical student, and Gabriel Schwartz, who is a graduate of our school and now at Drexel University. And the objective of our study here was to assess whether within-person changes in 2 different measures of housing insecurity, here we had measures of eviction and inability to pay rent or mortgage, were associated with changes in youth mental health and sleep outcomes over time. And to do this work, we use data from the Adolescent Brain and Cognitive Development Study, which is a large ongoing cohort study that recruited children between the ages of 9 and 10. And the long-term goal is to follow them over a decade. To this point, there's data available on the full cohort for 4 years. So that's the data that we used here. And on the map that you see on this slide, these are the different sites where data was collected. So in approximately 21 states across the United States. And so to say a few words about our measures, the exposures, as I mentioned, was we have caregiver report of eviction experience in the past year, as well as caregiver reports of not being able to pay the rent or mortgage at least once in the past year, so being behind. The outcomes for the study were internalizing and externalizing symptoms. So these are continuous scores from using the CBCL measure, the Child Behavior Checklist, as well as a measure of sleep disturbances that comes from the Sleep Disturbance Scale for Children, which is a large measure to assess multiple dimensions of sleep problems reported by the caregiver. Our modeling approach was fixed effects models. We had time-varying sociodemographic characteristics, including children's age, household income to needs ratio, the number of co-residing employed parents, and family structure. And for our models, we used random intercepts for the individuals and families and sites to accommodate the clustering that existed, because there were some families that had more than one child that participated. They either had a sibling or twin that could be in the sample. And for missing data, we used multiple imputation. And so on this slide, I just wanted to provide you with a description of the prevalence of our exposures in the study. So we see that across the 4 time points available to us from this study, that approximately 10% of households reported being cost burdened, meaning that they were unable to pay their rent or mortgage on time in the study. And we can see that eviction experiences were much less common. They, for the most part, overlapped with families also reporting that they couldn't pay their rent or mortgage on time, but it wasn't a perfect overlap. And that was approximately between 1 and 2% of the sample across the time points. And what I'm showing on this next slide are our standardized outcomes by eviction and housing cost burden. So on this first panel that I'm showing you here, I'm showing you the standardized scores. In blue are for the children who were not, did not experience eviction in the past year, and the orange dots show the standardized outcomes across time for children who were evicted. And we can see that, for our sleep disturbance scale, as well as our internalizing and externalizing outcomes, we see higher rates of symptoms just in this cross-sectional, in the longitudinal view, we see elevated rates across time. And the same pattern is true if we are using the exposure of housing cost burden. So elevated rates of sleep disturbances, as well as internalizing and externalizing symptoms, which with smaller confidence intervals, which reflects the fact that this was a much more prevalent exposure within this study. On this next slide, I'm showing you the results that comes from our fixed effects model. So these are our regression coefficients. And what we first did is that we ran models where we included eviction on its own, or inability to pay rent or mortgage on its own. And all of these estimates come from separate models. And so what we can see here across our outcomes, we see that eviction is associated with excess levels of the sleep outcomes, internalizing and externalizing. And this is true for the most part for our unadjusted as well as our adjusted models that included these time-varying coefficients. However, when we put both experiences into the model, we see that the coefficients retained their level of significance and had confidence intervals that did not cross 1 for inability to pay rent, but the confidence intervals did not retain their statistical significance for eviction when inability to pay rent was also included in the model. So, part of our goal within this project was to untangle these 2 different experiences, which we know are related to one another. So just to summarize, using fixed effects models, we found that within individual changes, an inability to pay rent or mortgage and eviction were associated with changes in mental health and sleep quality across 4 years during adolescence. And then we found that inability to pay rent or mortgage had a stronger and more consistent association with negative mental health outcomes than were observed for eviction. So, in other words, eviction effects were attenuated when we accounted for inability to pay rent or mortgage, which could reflect different forms of stressors within the household. Some limitations of this study is that we had a relatively short period of time. So the data only included children ages 9 to 13 years of age at the last time point of follow-up. We also did not have data on whether children were living in rented or owned homes, and these patterns could look very different on that basis. And there also could be exposure misclassification due to informal eviction. So some families may have experienced, let's say, increases in their rent because landlords wanted them out of the home, so they weren't, formally being evicted, but there could be an undercount of that experience on that basis. And we take these findings to suggest that there, these fixed effects models suggest that there's, implications of these forms of housing insecurity for children's mental health, and therefore these could reinforce the urgency of policy interventions that are aimed at preventing or reducing housing cost burdens for families. With that, I'm going to move on to the second study that I'm going to present. And here I'm going to share about a series of studies that I worked on with some colleagues that use a quasi-experimental design. And within this set of studies, the focus is on federal rental assistance and children's health. And before getting into the studies, I'd like to just give a little bit of background on housing assistance. So just for some statistics, the Department of Housing and Urban Development assists 2 million low-income families with children per year. And these benefits ensure that low-income families spend approximately 30% of income on their rent. And assistance is provided in 3 different forms. So there could be public housing, where all units are subsidized, multifamily housing, where some units are subsidized, and vouchers, where beneficiaries use vouchers within the private market. And an important point to make is that our current policies around housing and affordability are not adequate. And so we know that not all families that need housing assistance are getting it. So the visual I'm showing you here is that 16 million households needing federal rental assistance do not receive it, and that's due to funding limitations. So some common estimates that people report in the literature is that 1 in 4 individuals who need assistance are actually getting it. And so my colleagues and I that are listed on this slide, Andrew Fenelon, Sandra Newman, and Michael Boudreau, these are colleagues that I worked with when I was at the University of Maryland, we became really interested in thinking about housing assistance as a macro level intervention addressing this very important social determinant of health. So we got started on this series of projects by conducting a literature review. And what we found is that there's very little out there that has rigorously evaluated housing assistance and what it means for children's health. What we found is that there are very few studies. So in our systematic review, there were only 14 studies that were identified. The majority were cross-sectional designs. And a really important point is that for the most part, many of these studies did not use adequate methods to address selection bias. So if we were to compare health outcomes of children receiving assistance to the general population, that may not be the correct comparison group. We'd actually want to know, what does the health of children look like who are receiving assistance compared to those who need assistance but don't get it? And that type of comparison was quite rare in the literature. And we also found that within the existing studies, there was a limited range of health outcomes that had been considered. And so we ended up working on a research proposal that was funded by NICHD that essentially asked this larger question of, could greater investment in rental assistance lead to better outcomes in children? And so we worked on a variety of studies that looked at rental assistance in relation to children's asthma, in relation to school-related outcomes, mental health, and neighborhood outcomes. And I'm going to just give an example today describing the study that we worked on that looked at childhood asthma. And now to say a few words about the study design that we used, that we thought could be a complementary piece of evidence adding to the literature that had existed. And we were capitalizing on a new linkage that was made available by a collaboration between HUD and Census Bureau that linked existing data to HUD records in a way that hadn't happened in the past. So for our study, there was information about rental assistance that we derived from HUD administrative records. So this is a longitudinal record that could be linked to other data coming from the National Center for Health Statistics. For the projects that I'm describing here, we linked it to the National Health Interview Survey, which, as many of you may know, is a sort of surveillance study in the United States, repeated cross-sections that are done on a rolling basis. So we had the administrative HUD longitudinal record that was linked to child health data coming from the National Health Interview Survey. And essentially, we were doing a comparison between the health status of children who were receiving housing assistance at the time that they participated in their National Health Interview Survey compared to children that were in the National Health Interview Survey that we could see from the HUD longitudinal record received housing assistance 2 years later. And the reason that this comparison is of value is because we know that the average wait time for families that would like housing assistance is approximately 2 years. So this linkage allowed us to create sort of a quasi waitlist design, or approximate people that we knew were in need of assistance but needed to wait that 2 years to get it. So that's the comparison that we made across the range of studies that I presented on the prior slide. So to go into depth on our the asthma study, it was led by Michael Boudreau. Here we were looking at children ages 0 to 17 years. It was approximately 3,000 children. And our outcomes were if the child had ever been diagnosed with asthma, if they had an asthma attack in the last year, and if they visited the ER for asthma in the last year among those having an asthma attack. And so just to give you a little bit of data about our sample, we see that, on average, the pseudo waitlist and the children receiving housing assistance looked relatively similar. There was a bit of a difference in age, but then it was balanced based on sex and race, ethnicity. And what I'm showing on this slide is the key results of the study. So I'm showing you the results from 4 different models, but you can just focus on the darkest blue bar, which is adjusted for individual demographics along with family SES, healthcare access, and neighborhood characteristics. And so as you can see, among children with an asthma attack in the past year, participation in rental assistance reduced the use of emergency rooms for asthma by approximately 18 percentage points. We do not see evidence of changes to asthma attack or asthma diagnosis, for example, but just this ED use is what appeared. So to summarize our findings, among children receiving rental assistance who had an asthma attack, there was a 15 to 18 percentage point reduction in ED use for asthma compared with children waiting to enter a program. And I'll just make the point that these results align with the other studies that we worked on, where we saw benefits of receiving this assistance for children's mental health as well as school attendance. Some limitations that apply across the studies that we worked on with this design is that we can't exclude the possibility of group difference, that the group differences we observed were associated with factors other than entry into a housing assistance program. And we also have to acknowledge that the study period extended back to 1999 and therefore may not be generalizable to current HUD programs. But that said, we believe that these results have important implications for the well-being of low-income families and also may speak to the potential value of housing assistance programs for healthcare system costs, specific to this ED outcome that we saw in this project. Great, so I'm going to now move us on to the third design that I'll provide an example of today, and this study uses data coming from an experimental study. So the study here that I'll be presenting on is mechanisms that connect housing assistance to improve child outcomes in the Family Option Study, which is a randomized trial. Just to tell you a bit about the Family Option Study, which was the source of data for this project, that's where I'd like to begin. So this was a randomized controlled trial in 12 different US cities, as illustrated on the map that you see to the right. And the goal of this large intervention trial was to produce evidence on the types of housing services and interventions that are most effective for families that are experiencing homelessness. So the study considered 3 different types of interventions that were randomly assigned to the families enrolled in the study. This included permanent housing subsidies, community-based rapid rehousing, and project-based transitional housing. And I'll say a few more words about each of those on the upcoming slide. But a point I want to make is that each of these groups was compared to a usual care condition that was available in the community. And each group had its own comparison group to usual care based on the fact that not all of these sites had all of these programs. So there were 3 usual care groups that matched each of these 3 intervention groups. The study enrolled 2,282 families, including more than 5,000 children who spent at least 1 week in an emergency shelter, with an enrollment occurring between 2010 and 2012. The study conducted surveys at baseline prior to randomization, at 20 months, and at 37 months, so approximately 3 years out. And just to show a schematic of the intake and random assignment procedure, as I had mentioned before, families were recruited from emergency shelters with who had been there for 7 or more days with at least 1 child aged 15 or younger. And then they were assigned to one of the 4 conditions for which the family was eligible. Here I'm showing you the variety of sites that participated in the study and the number of individuals assigned to each condition. And the point I wanted to make here is that this was a study that made use of existing resources. There wasn't balance across all of the sites in terms of every site having the exact same number of individuals assigned to each condition, because this was constrained based on what was available across the cities. But the primary overarching question of the study was, does priority access to a particular type of housing intervention yield differences in outcomes across parents and children in the short term and in the longer term? That's the 37-month time point. Before I get into the key results of the trial and then our study that we conducted recently using this data, I just want to say a few words about sort of the theory behind each of these interventions. So for the subsidy only, this is a permanent housing subsidy with no supportive services attached that was typically delivered in the form of a housing choice voucher. And so the theory behind this would be that family homelessness is primarily an economic problem. So if families can be provided with a rental subsidy, this could reduce stress and allow families to spend household income on other needs. The second condition was project-based transitional housing. So this is temporary housing for up to 24 months with an intensive package of supportive services offered on site. And the theory here is that families experiencing homelessness face a number of non-financial challenges that need to be addressed by laying the foundation for housing stability. And the third condition the third intervention was community-based rapid rehousing. So this is temporary rental assistance, renewable for up to 18 months with limited housing-focused services. And the theory behind this intervention is that families require short-term support to overcome whatever income shocks or other crises may have precipitated the homelessness that they were experiencing. And so now I will say a few words about selected findings at 37 months that laid the foundation for the project that I worked on with my group. So at 37 months post-randomization, the study found that assignment to project-based transitional housing and community-based rapid rehousing had very few significant effects for children. However, the children assigned to permanent housing subsidy intervention did display a number of positive outcomes, including that they had fewer sleep problems, as reported by the parents, and they also displayed better emotional and behavioral outcomes on the SDQ. So there were also outcomes that were observed at the family level for the permanent housing subsidy intervention. So we saw that families assigned to the permanent housing subsidy intervention showed improvements in the likelihood that they had a shelter stay after random assignment, improvements in the likelihood of living in a doubled up home. The parents showed lower levels of psychological distress, as well as lower levels of drug and alcohol problems. There were also lower levels of household food insecurity and lower levels of intimate partner violence. And so it was on the basis of these findings that we worked on a secondary analysis using this study. So I'm going to talk about a study. The first authors a research associate working with me named Renee Wilkinson, who I believe is affiliated with the epidemiology department, Ashna Lal, an MPH student here, and then some of my prior colleagues at University of Maryland, Michael Boudreau and Andy Fenelon, and Mary Beth Shin, who was a PI on the family option study. And our objective here was to identify and analyze the pathways through which housing assistance interventions impacted children's emotional behavioral problems and sleep outcomes. And so for this study, we included approximately 2,500 children from FOS, the Family Option Study. So we included all of the focal children that were in the 37-month follow-up that were born prior to a random assignment. And the retention rate here was approximately 70%. So our design was a longitudinal mediation analysis that utilized data from the follow-ups at the 20 and 37-month surveys post-randomization. So our exposure was the intervention condition. The outcomes were children's behavioral and emotional problems in the past 6 months, as well as sleep problems, which just was 2 items from a scale. We had a variety of mediators that we saw evidence for from the main trial. That was family homelessness, food insecurity, parental psychological distress measured with the Kessler-6 scale, economic stress, and intimate partner violence in the past 6 months. For our control variables in this analysis, we included all of the controls that the group that conducted the main evaluation, that was APT, included in their trial results. So we adjusted for the age of the head of household, sex, race, education, number of children living with the family in the shelter, annualized earnings, prior history of homelessness, employment income, disability, and child age and sex. And all of our models clustered at the family and site level because we wanted to take that into account. All right, and so to conduct our analyses, we use generalized structural equation modeling to examine the indirect effects of the independent variable on the outcome through multiple mediators. So the individual indirect effects were calculated as the product of each mediator's regression coefficient, linking the independent variable to the mediator and the mediators to the outcome. And the total indirect effect was computed as the sum of the individual indirect effects, accounting for the variance and covariance between the mediators. And so I'm showing on this slide selected characteristics of the children and families at baseline. And as I mentioned, each condition is compared to its own usual care comparison group. That was the design, that there would be these 3 sets of pairwise comparisons that took place. And all numbers are rounded based on census disclosure rules. But you can see in the top row the approximate number of children per condition. So we see that on average across groups, the children were between the ages of 5 and 6 years old. The caregivers were approximately 30 years old. The majority of the head of households were female, over 90% across groups. And we see that on average, there were two or more children in each family. Okay. Now I'm going to show you data that came from the main intervention trial, just to set the stage for the analysis that we did. And so what I'm showing here is the intervention effects on the child outcomes and potential mediators. And this is what I summarized on the slide earlier. So we can see that when we compare the permanent housing subsidy to usual care, we see improvement in emotional and sleep problems. That's the SDQ scores, are the emotional behavioral problems, sleep problems, and we see improvements across the mediators of homelessness, lower risk of intimate partner violence, food insecurity, lower levels of economic stress, and psychological distress. However, we did not see these same patterns and benefits for the other 2 conditions of rapid rehousing or transitional housing. And so for that reason, we focused our analysis of mediation to this permanent housing voucher condition. And so I'm now going to share the main results of this of our look at the relationship between the potential mediators and the child outcomes and the indirect effects. So first, looking at the emotional behavior scores that come from the SDQ, the Strength and Difficulty Questionnaire, we can see that that there was the mediators were significant, the mediators of economic stress and psychological parents, economic stress and psychological distress showed these positive associations with the children's scores. And we also see significant indirect effects for these two factors. So there's a significant indirect effect for economic stress and psychological distress. And if we look at it together, we can see that approximately half of the impact of assignment to long-term rental subsidies versus usual care on the improvements in children's emotional behavioral problems were operating indirectly through lowered parental stressors, so specifically economic and psychological distress. When we conducted the same analysis for the sleep problem scores, we saw some evidence for an association between sleep problems and between economic stress and psychological stress and the children's outcomes. That's the same analysis here. But what's different this time is we did not observe evidence for much evidence for an important indirect effect. So the impact of assignment to long-term rental subsidies on improvements in children's sleep outcomes was predominantly direct based on what we saw here. There was minimal evidence for mediation through these two pathways. So to summarize, lower parental stressors were the primary mechanism linking permanent housing subsidies to long-term improvements in children's emotional behavioral problems. And these mechanisms accounted for approximately 50% of the association. However, we did not find evidence that any of the mediators that we considered were relevant to the intervention impact on children's sleep problems, potentially indicating that factors inherent to stable housing itself are what may be critical for improving sleep. Just to highlight some limitations, though, we know that the mediators were self-reported, and there could be some social desirability bias related to sensitive questions, such as intimate partner violence or food security questions that people may not want to disclose. And then importantly, the mediators were not randomized. Therefore, the mediator outcome relationships could be confounded by unobserved factors that we weren't able to control for in our study. And the implications of our results is that additional research is needed to identify other modifiable pathways that can lead to improved child outcomes. So with that, I'm going to now move on to conclusions, and then we'll be happy to take questions. A big takeaway, I hope, from my presentation is that we can use diverse approaches and study designs to advance our understanding of the relationship between housing insecurity and children's health outcomes. And by using a variety of study designs, that we can add value to the research evidence and hopefully have greater implications for policymakers working on this topic. So using a fixed effects model, we were able to leverage within individual longitudinal data that allowed us to control for unmeasured time invariant confounding, isolating the effects of housing insecurity on children's mental health and sleep outcomes. Using a quasi-experimental design, we were able to capitalize on known wait times for access to federal housing assistance, which helped us to approximate causal effects in the absence of randomization. And then finally, the randomized design of the Family Option Study provided robust evidence on the differential impacts of housing intervention types and allowed us to rigorously examine underlying mechanisms. So with that, I'd like to acknowledge the co-authors that worked on the projects that I presented here. That's Nigel Harriman, Ashna Lal, Bruce Rampel, Renee Wilkinson, Gabriel Schwartz, Andrew Fenelon, Michael Boudreau, Sandra Newman, and Mary Beth Shin, and acknowledge support received. So I'd particularly like to acknowledge the Broad Trauma Initiative led by Kirsten Conan. She's provided support for some of these projects, recognizing that eviction is a form of trauma that requires further study, as well as support that we've received from the Initiative on Homelessness and Health, which is led by Howard Koh and is based at Harvard Chan, and really a wonderful resource for anyone on this call that is interested in this area of research. And then I'd like to acknowledge additional support from NICHD, as well as the HUD Data Use Award that gave us the opportunity to analyze the Family Option Study. So with that, I will thank you and stop sharing and happy to take questions.
Dr. Sloper Natalie, thank you very much for a wonderful seminar. It's clearly a very, very interesting and important topic, and you brought also a wide range of various approaches from observational to experimental. I very much enjoyed it, I may say. Let's see whether others have the same. May I invite questions or comments, please? Yes, I have Dr. Lourdes Sariol.
So I'm a housing advocate in the community. I do a lot of housing work through the city and through Brigham and Women. And one of the questions I had was earlier on in the slides where you presented the chart of the sleep disturbances. It seemed to have spiked in year 2 and then went down without, it didn't seem like there were a correlation to your later data about sleep. Did something happen when it peaked? Was it that it was the interventions were greater, so more came to light and then subsided? I just wanted to understand a little bit more about that. And then I have a follow-up question also.
Sure. Thank you very much. I believe that you may be asking about the first study, and if so,
Yes.
that was actually just observational data. So what you may have observed in year 2 just happened to be the second year of the study. There wasn't an intervention in that study. So what we could look at, and I haven't, is, did that spike because perhaps there was something temporal that could have been close to COVID times? I'm not sure. So that's one possibility. It could be developmentally. That's a time when children experiencing more sleep problems. So I will thank you for your comment, and I should absolutely take a closer look at the pattern you're pointing out.
Before we go on, I would like to say, and thank you, Beth Williams, for reminding me that the Q&A is being recorded. So I'm not sure, Lourdes, that makes a difference for your question very much, but that everybody knows that. You had a follow-up question, Lourdes, no?
I did, and it had to do with the results of permanent housing versus some of the other models, such
Yeah.
as rapid rehousing, or now what's being called home base, which are temporary. And I was wondering if there was any possibility of a further look at that, because it does seem to, we see it in the community, the impact, because these families always come back through the pipeline, and then the situation is worse for the family. It just keeps them in that trajectory of long-term homelessness longer than need be, versus putting those resources into permanent housing. So I'm very, very interested in that. And maybe the state might be too.
Okay, thank you so much for that comment. Yeah, thank you.
Thank you very much. I have Andrew Rowland, please go ahead.
I very much appreciated the path-breaking nature of the work and adding to what we understand about the social determinants of health in a new way. So I really appreciate the work you've done. I did have a question about the first study and the way you summarize the results.
Mm-hmm.
It seems like it's very difficult to separate out costs from eviction, because they see so entwined. And I wondered if the interpretation should be that the model shouldn't have both things in at the same time, that it's on the causal pathway. And I just wondered how you were thinking about it, because it really leads to a different conclusion.
Yes, thank you. So it's a great question, and that's part of why we started with looking at these individually, and I would say that we view all of the models as informative and not necessarily prioritizing the model with both exposures as the main takeaway. But I think that, we see this evidence for change, the incidence of an eviction and incidence of nuance of this household struggling to pay rent. They both independently, in separate models. But if we consider them together at the same time, I do hear your point that, when they're both in the model, you can't untangle that one is more important, or but we felt as though it would be of value to look both ways. But I really appreciate what you're saying, because this is a work in progress. So we'll think carefully about how we interpret. Thanks.
Thank you.
Thank you.
Thank you. Any further questions, comments, suggestions?
To be available.
I can email them to you, so I'd be happy to. Yeah.
Thank you.
If you raise your hand, can I ask a question? Perhaps it's a
Sure.
naive one, but I'll give it a try. So I was very impressed with, of course, with your experimental design and the usual care element in it. I have two questions. One is, given that probably the outcomes like emotional behavior, sleep, are relatively subjective outcomes, is it possible that there has been information bias? They knew to which they were, in which group they were. Possible that has biased the results. That is that's one question. So that you
Yes.
find a result that really is not there. And my second question is, well, let's take this one first.
Okay, I think that that's a great point. Like, obviously, participants are not blinded to the condition that they were in the trial. So I appreciate that comment, and I think it's a limitation we can raise. I think that the child outcomes also do have some element of subjectivity, but I also think that the mediators, some of them are more concrete, like intimate partner violence, or if they're struggling with food insecurity. So I think there's variation in how subjective some of the responses will be, but you're making a great point that should absolutely be acknowledged. And I think that, a goal might be that we could perhaps link some of this earlier data to, let's say, administrative records. So there would be this opportunity to avoid only relying on survey reports.
Yeah. Thank you. Well, my other question was, you have 12 cities, you have different usual care there, I presume. Can you, and this is then in a trial in an observational way, can you learn something from these differences in usual care and how the effects you see then as compared to, say, the permanent housing subsidy?
Thank you. So it's a great question. And unfortunately, because of the sample size, you really cannot do much at the site level for this project. But we know that these sites have very, very different contexts. So that's a limitation as well. But great points. Thank you.
Yeah, there's a general epidemiological lament and a small sample size. You cannot answer all questions. Yes, Mary Kay Stranik, please go ahead.
Yes, I'm part of a group in Minnesota, one of the states that you had some data from. And the group that I'm a part of is called Elders for Infants. So you can probably tell where my question is going to go. I'm wondering about the advantages and disadvantages of these broad categories of research, because we all know that with children, each phase of development is so totally different than the others, what it needs from the family and the effect of all these environmental things on the child. And so I'm wondering if you could comment on that, because with all the brain development information coming out of the Harvard Center on the Development of the developing child, I mean, it's so clear that resources should be focused on the pregnancy to age 2 or age 3.
Great. Well, thank you. I'll just thank you for your comment and the acknowledgement that we really do need to be focusing our resources on the earliest years of life, particularly knowing that that's the age group facing the greatest risk of, let's say, homelessness in particular, and many forms of housing insecurity. So thank you for that comment. I totally agree.